So let's now talk about guide options. Now we're going to use guides. You feel more comfortable in planning CT-related information. So is it accurate? And there's certainly a number of publications which show that it has significant accuracy. I think everybody's familiar with the work of David Sarmet, but most recently a Valenti article basically confirms this. So you want to be able to select a guide option that facilitates the needs of that patient. So you should be working with a company that can generate guides that fall into these categories. It's not always mucosa, it's not always tooth-borne. You need to have the flexibility and the variability. So let's take a look at this case. Now, periodontal disease does still exist in the United States, but this is probably the only advanced case that I've seen in a relatively long period of time. Well, where are we going to go in managing this particular patient? This is the patient that had the artifact as a result of the implant placed on the lower right side because we were going to place a provisional restoration for this patient. And you can see 2 teeth, a molar, and the implant are going to support the provisional restoration. So here we are using a traditional SurgiGuide, which allows us osteotomy control. Why did I want to do that? Because I didn't exactly know where the bone was. So by doing things chair-side and calculating measurements, we're able to use this guidance to set the implants up so that we could end up with a very successful prosthesis at the end. Okay, so this can be done. And this is the result of the implants relative to the radiographs. So let's talk about navigation. We're ratcheting it up now to another level. The more you become committed to a totally guided implant case, the higher the risks, the greater the benefits. Keep that in mind. So let's talk about totally guided. You can have appliances that are removable, as Scott showed. You can have appliances that are fixed in place. The choice is yours. Again, we have many supportive options that we can select from. So, one of the more recent articles by Arison talked about the accuracy of guides. And what they found out, and I'll kind of point out the highlights, they had successive bone guides, and then they had guides that were fixated. And Scott and I would certainly understand this. They had more success with the guides that were fixated or used as a single guide. Wherever you're changing guides, using multiple guides for successive osteotomy preparations, the accuracy diminishes. So let's talk about these guided navigation systems. They're pretty accurate. They're sophisticatedly engineered. They're efficient, but they're programmer dependent. Who's the programmer? You and I. So you need to understand a very important concept that all of these systems are brain dead. There's no life to any of these systems at all until the CT-related information from your plan gets infused into that particular delivery system. So you can have something that knocks your socks off, and then you can have something that absolutely disappoints you and breaks your heart. So here's the box of pieces. Now, how does this box become alive? Well, what we need to understand, and Scott emphasized this many times, is that the patient-specific nature of any of these systems results from the doctor's collaborative, prosthetically directed, I want to emphasize prosthetically directed, plan using interactive planning software. So the question now is, are you willing to turn this responsibility for the plan over to a third party that may not even reside in this country, so that you can have a guide fabricated, take it to the surgical arena, and now start preparing osteotomies on your patient? So here's the overall concept. You've got your surgical components, you've got your laboratory components. And the design is to make them interchangeable. So you could design something in the lab and bring it to the mouth, or you could design something at the time of surgery and then have it fabricated laboratory-wise. And most of the systems will provide axial and vertical control. And so that's very critical. But not all the systems provide rotational control. It's going to emerge, it's going to happen with all the systems, but as Scott was showing you with the little dot facing the buccal, that's the example of the control. And you get a cheat sheet. Every one of these systems comes with the cliff notes. And these cliff notes, does anybody know what cliff notes are? I see such a young audience here. They probably don't have it in a book form anymore. It's probably on a PDA. But essentially, you get all this stuff. And it's your dental assistant who's interpreting all this information, assembling everything for the time of surgery, but it all happened before that day. So let's talk about diversity in clinical application. It's somewhat ironic that the case that I'm showing you is exactly like the case that Scott showed you with the lateral incisors. Now, Scott didn't tell you why it was so great to pick that case. Basically, when he took the tooth out, there wasn't a socket. So he's no dummy. He understands that. So following in Scott's footsteps, unbeknownst to Scott or myself, we decided we would work on, this is the very first proof of principle case in my practice where I'm going to take out a lateral incisor which has no purchase point in the socket. It's basically a flat crest. And so with the use of this technology and the planning, and we didn't need a scanning appliance because the tooth was there, but we needed to make sure that the tooth was in the right position at the time of scanning because this tooth had Class 7 mobility. Does everybody know what Class 7 mobility is? It's when the movement of the tooth is directly related to the tidal volume of inspiration and expiration. So when the patient inhales, the tooth moves to the palate. So that's significant mobility. So we can use different tools, and you know the real tough part about learning the software, it's crazy. You got all these buttons to push, but the reality is the software should be learned in reverse. The question is, what information do you need to make a better decision? And then you learn where that particular component of the software is, such as this transparency tool, which Scott alluded to as well. Ultimately leading to a pretty precise development of where the emergence is going to be. And yes, we think that there might be the potential for a dehiscence, but in a flapless approach and not disrupting the periosteum, that really becomes a non-issue. It becomes a non-issue proactively, not reactively. And so we can now take our surgical guide, we can go to the laboratory, we can fabricate a precision provisional restoration, all done in the lab, setting the analog, developing the provisional restoration with proper hex timing, and set up the provisional. So this was the first case, proof of principle. Is this going to work? So here we are now repeating what we did in the lab now at the time of surgery. The guide is seated, and it's very important when you're seating these guides that you have simultaneous bilateral engagement. And here we are now introducing the implant through the implant mount. Again, repeating what Scott mentioned before about the absence of trauma to the soft tissue. Although you saw Scott use a forceps, I just about used my fingers. That's really atraumatic. And this is the immediate postoperative view of the temporary cylinder in place. And you may ask, well, gee, I don't see the restoration. Well, that's because a naked temporary cylinder was fitted to the implant to make sure that we could seat it. Because when you go to seat an immediate provisional restoration, whose axial alignment may interfere with the marginal ridge contacts of the adjacent teeth, you want to rule out the variable of the implant coupling with the temporary cylinder, so that your only restorative issue now is managing the interproximal contacts. So here we are now at the completion of this patient's treatment. And this was completed over about a 4-month period of time. Again, very similar to what Scott presented. So it's not that we're showing you things that aren't done on a consistent basis. So let's take it up a little bit more. Let's combine disciplines. We have 2 anterior 3-unit bridges. The midline is not joined. We have a ponic in the lateral incisor area. We have a significant amount of intermaxillary wear. And there's a need to provide some crown lengthening and implant placement and provisionalization from 6 to 11. Now the question is, can you actually enter a surgical prosthetic arena with the confidence that if you follow the plan accurately, you can develop a successful solution? So let me take this forward. Scanning appliance, development of the images. This is the other lateral incisor. There's a feature where you can actually spin the implant around called implant centric. So 360 degrees, you can check the bone around the implant. How would you know that feature? Because you saw it here and you'll remember it and you'll learn that there's a button to press to do that. So, provisionals are made in the lab. Our interproximal reduction in terms of crown lengthening is really what we're after to achieve. And here we are now at the time of surgery. Now, the tense part is that I'm taking care of a restorative doctor's brother, and the restorative doctor is now with me at the time of surgery, and so the weight of the world is on my shoulders. So we open the area. We do our necessary circumferential crown lengthening. This is the post-osseous. We had a pretty thick ridge. Again, you see, Scott and I know to pick the cases. This is not one where you have to combine bone grafting and so on. This is straightforward in terms of bone volume. We have the guide. We suture the flap in all the interproximal areas. We have the little bit of unsutured area there, which is open. And we're now going to go ahead and we're going to introduce the implants. But I want to call your attention to something that nobody talks about. When this implant mount and this implant enter that cylinder, the guidance does not begin until this implant mount engages the cylinder. In fact, your implant may not be entering the osteotomy correctly until there's this engagement. So there are errors that creep up in a number of different areas. But the hex timing is being checked. Remember, the provisional restorations were completed. And here we are now at the completion of surgery with 2 screw-retained provisionals in this area, which is my preference to avoid cement sepsis and contamination. So, minimally invasive? Yes, because it was the least amount of treatment to get the maximum result under control for this particular patient. Was I nervous about this patient's deep overbite? You bet. Was this the smartest decision in the world to go ahead and try to relieve the intermaxillary occlusal relationships? I'm not sure. But if anybody in this audience decided that the risks of immediately loading the implants is too great, that's perfect. That's a professional and a biologically sound decision. So these are the final restorations. And again, as Scott mentioned, if the implants are in the right place and the parallelism to the adjacent teeth are there, we can achieve predictable end results, as you see here, and then ultimately the radiographs that are here. Okay, let's get a little bit more risky. This is a patient who's 70 years old, has pretty significant crowding issues and periodontal disease in the anterior part of the mouth. How are we going to sequence this particular case? What are the space appropriation needs that we have to deal with? Well, I don't think there's anybody here in this audience that's going to go ahead and place implants immediately in this environment. So what do? We go ahead, we extract the teeth, we do our requisite GBR procedures, but look at the information we have before we start treating the patient. Number one, we're going to have a facial dehiscence. That's a risk the patient needs to assume along with you and the restorative doctor. There's going to be bone grafting that's going to need to be done. And in fact, we have embrasure problems in trying to get the appropriate sized teeth, and we also have hardware problems. You know, part of the issue here is do the guides and do the cylinders and does the hardware, does it fit into the area that we're working surgically? So let's take a look. This is post-GBR. Well, we have kind of a scoliosis tooth over here with advanced disease. We have a ridge that's not all that impressive, but certainly is a lot better healed than it was before. And so we have problems relative to this axial position of that tooth. We've got incisal space appropriation problems, and we also have crestal bone appropriation problems, as you see here. So entering this particular situation, we electively decide to remove the cuspid because we know that we can get a decently sized implant in that area, and we'll have smaller implants in the other areas, as you see here. But look at the challenge of getting this equipment in that area. You can see how minimal the support is for the guide over here. So here we are. Well, this is not a surprise. These dehiscences we expected. So our bone graft materials have been selected, our membranes have been selected, the appropriate informed consent has occurred, the staff knows what's going on, this information goes beyond just what Scott and I have spoken about. It really has to do with managing our offices and managing our patients as well. So we do the usual stuff. We get stuff out of a bottle. We put a membrane over the area. We actually attempt to hope for the best. Okay, so this is how things looked at the time the implants were placed. We did a delayed approach, as you can tell, because of the bone graft. We're placing our healing abutments on, and this is the environment now that the restorative doctor is working in, knowing full on from the beginning that there were going to be embrasure issues, and this was going to be a screw-retained prosthesis. So this was the outcome for this particular patient. All right, let's turn the volume up another notch. We're going to go ahead and we're going to manage this patient. Significant periodontal disease, significant decay, crowding, implant failures in the posterior area of the mandible, hygiene that would certainly not favor any of us, which certainly suggests why she's in the trouble she's in. And so we're going to go ahead and we're going to remove these teeth. And when we develop a plan, we're going to have a couple things in mind. It's very interesting that Scott showed you the risks of the actual symphysis area of the mandible. There's a superior genal spinal artery foramen in that particular area. Doesn't usually present problems, but it certainly is nice to know about it so that you can take appropriate precautions. Well, there's inter-implant distance issues, and we're going to have to do precision osteoplasty. And this view here is indicating the crestal relationship and how the implants are going to be placed below the crest of the bone. You saw the same exact thing that Scott showed you. So this is showing you now the position of the implants. And we elected to have the guide designed to fit on the native bone and reduce the bone later. Failed implant previously. We have guides. We have RP models. This can be mounted on an articulator. We can set the case up. So here we are at the time of surgery. I spent 45 minutes debriding this patient because I wanted to reduce the effects of bacterial contamination. So here we are. We're going to take these teeth out. This is after the teeth are extracted. How are we going to navigate through this mouth to place implants, reduce the bone, provide an immediate load prosthesis, have the patient leave happy and pleased? So we use our surgical guide. This surgical guide commits us to being able to develop osteotomies within extraction sites at precise locations, ultimately placing the implants below the crest of the bone, which then leads to, and you can see the bone levels here, substantially long implants, and ultimately reducing the bone levels and then going ahead with some bone grafting in this particular area. And then on to the immediate prosthesis for this patient, as you see here, and we took care of that mucogingival issue as well. So here are the implants now at the time of moving on to the next stage. This was about 5 months. This is the patient's final prosthesis, but I just wanted you to look at the bone levels 20 months later. Okay, certainly pretty good. But I have to tell you, the technology has nothing to do with the bone levels that you see. It has to do with the fact that we understand there are certain drilling protocols that we need to use so as not to overheat the bone when we're drilling 15 to 20 to 25 millimeters away from the tops of these appliances. It's not a drill press. Okay, final case and then some concluding remarks. This patient I treated in my office 3 weeks ago. And when I'm standing in the Cairo airport for 18 hours, I never knew whether I was going to see this patient again. This patient is an orthopedic surgeon that's a medically complex patient who comes to the consultation and says, I know everything about you. Well, that can't be good, because if he knows everything about me, there are skeletons there that, I wouldn't want him to know. I said, well, what do you mean? He said, well, I read your book. I said, really? He said, yep, being an orthopedic surgeon, having several patents and so on, he read the book and he said, I understand. I said, okay, great. So we're now going to go through the process of developing maxillary implants, immediate load prosthesis, on a patient who has significant elevated blood pressure. He's a diabetic. He was telling me when I first met him, he told me, do you know what MD stands for? I said, I think it's medical doctor. And he says, mass destruction. That's a commentary on my personality and my lifestyle. So, here we are with a panoramic x-ray. We have a bite registration, which is going to make sure that the scanning appliance is fully seated under pressure so that there are no air pockets that are visible on the CT scan. Here's the requisite plan. You've seen these before. We're going to have this fixated in a number of areas. I happen to like to use a mid-nasal septum fixation. I find it to be very, very stable. We can see where the implants are going to emerge. But look at the biomechanical concerns. Look at where these teeth need to be, and look where the maxillary bone is. That's a significant, biomechanical disadvantage. So the ability to have a discussion with the restorative doctor and the patient and the lab and myself to put responsibilities where they belong occurred prior to the procedure. So this is a virtual duplicate of the scanning appliance. And what we're able to do now is use technologies where we can actually have models that represent the soft tissue. You remove the soft tissue portion, you can see the bone. The analogs are inserted into this model, and we can see how the virtual duplicate of the scanning appliance fits on this model, as well as the surgical guide. So we now have the ability, as Scott mentioned, to select abutments, determine the vertical height of abutments, get all of these things taken care of so at the time of surgery, we're in control. We're in control. Prosthesis was fabricated by using a special mucosal support holder, which means that the dentist was able to try in the provisional restoration prior to the surgery to confirm lip support, intermaxillary relationship, and ultimately this holder is removed at the time of surgery after the appliance is joined to the implants. So here we are now using all of these interrelated technologies, selecting temporary cylinders and abutments, which are going to be placed on conical abutments. And basically, all of the issues relative to the restorative regime are worked out ahead of time. You get your cheat sheet, and by this time, if this hasn't undergone due process, this does not mean anything. So here we are now at the time of surgery. We're trying in the patient's final provisional restoration supported by the holder. We're removing the plugs where the osteotomy sites are going to occur. We're using the same related technology that you've seen case after case after case. You can see the intermaxillary relationship. We've left some of the teeth on this particular appliance. We're always confirming that the intermaxillary relationship is correct. We're going through the sequence of doing the drilling, which actually is quite quick. We're introducing the implants. Ultimately, all of the implants are introduced. And today we use either Ostel or perhaps insertion torque to make sure that the implants that are placed have some degree of firmness and competency. Because when you insert these devices into these little cylinders, you lose all of your tactile sensations as to what we're really talking about in terms of resistance. Is it the cylinder that's engaging the holder? We really don't know. So we try to test as best we can through Ostel as well as insertion torque to find out the stability of the implants. So here's the provisional restoration that's going to be placed. This is the provisional following the surgical treatment. And again, these are the implants being placed. And look at our ability to place the implants close to the anterior wall of the sinus. Okay. Here's my take-home message. None of this stuff is a substitute for experience and good judgment. And I will tell you that any time you as a clinician rely on the technology and you don't rely on yourself, you've just committed a significant professional omission. Always go with your gut reaction. Always go with your clinical intuition. So let me conclude with the following. Scott talked about some errors, and these are some of the things that you need to know about in order to minimize errors. There are accuracies and inaccuracies relative to CT imaging as well as the acquisition and data processing. You need to know about that. You need to know about the reliability of the 3D reconstruction. Is it dependable? We need to understand that some of these models that are made may be inaccurate, and so you need to confirm the intermaxillary relationships, both in the patient and articulation. The ability to differentiate structures may be difficult. Thin facial bone may be imperceptible on a CT scan relative to the tooth structure. You may not be able to determine where thin facial bone is. What about influential anatomy? How does this alter what we do? And what about the accuracy of the optically scanned model for tooth-supported cases? And Scott talked about that. And what about the stability of the scanning appliance at the time the patient is imaged? And what about image capture artifact that we may have to deal with? What about the movement of the guide at the time of surgery, when you're in the heat of the battle and you don't recognize things are changing before your very eyes? So, I want to conclude by just making a few final comments. First of all, it's been an honor and a pleasure to come and address this audience. And the reason that I feel being here and taking the topic to the way in which I approach it is because each and every one of you, the young faces in the audience, have a responsibility to carry on the work that Scott and I and Philippe and others have done, because this technology has the ability to develop into a bad reputation very quickly. But if you play by the rules, if you're true to your profession, if you understand the biology of what we're doing on a day-to-day basis, you will be excited and motivated beyond your wildest dreams relative to this. So again, I want to thank all of you. And again, Michael, thank you so much for your honoring Scott and I and Al Mattia. But thank you very much for your attention.